Welcome, and thank you for taking the time to join this presentation on cultural competence and veterans' whole health. In this talk, I will focus on how we can care for veterans as whole people, mind, body, and spirit, while also recognizing that veterans form a distinct culture with their own language, values, and ways of relating to one another. The goal is not only to understand clinical issues, but to think about how our communication, our systems, and our public health approach can honor veterans' lived experience. The U.S. Department of Veterans Affairs has been transforming its system towards what it calls whole health. Whole health is described as an approach to care that empowers and equips people to take charge of their health and well being, grounded in what matters most to them rather than only what is the matter with them. This shift forms a purely disease-focused model to a whole person model is especially important for veterans whose health is shaped by combat exposure, transition stress, moral and spiritual questions, and the long-term impact of military service. Throughout this presentation, I will return to two key ideas. First, that veteran identity and culture shape how people experience illness, healing, and trust in the health system. Second, that a whole health approach, which integrates mind, body, and spirit, can create more meaningful, culturally responsive care and can reduce preventable suffering when it is implemented thoughtfully and equitably. On this slide, you see the learning objectives that will guide our time together. By the end of this presentation, you should be able to identify several defining features of veteran culture that influence communication and health behaviors. You should also be able to describe the basic elements of the VA whole health model and explain how it differs from traditional problem-oriented care. A third objective is to examine some key public health issues that affect veterans, including mental health, moral injury, and access to care. We will connect these issues to structural and social determinants of health and talk about how public health practitioners and clinicians can work together to address them. A fourth objective is to review practical training and educational resources that can support ongoing cultural competence and humility in veteran care, including whole health training, peer learning, and community-based options. Finally, I will invite you to reflect on how you, in your own role, can apply these concepts to build trust with veterans and advocate for systems that support their whole health. Veteran culture is complex, diverse, and often misunderstood. Many veterans describe the military as not just a job, but a way of life that shapes their worldview, communication style, and identity long after they separate from service. Lynn Hall describes military culture as a distinct subculture with its own hierarchy, rituals, humor, and expectations for loyalty, duty, and self-sacrifice. Understanding this culture is a prerequisite for effective care. One key aspect is the emphasis on self-reliance and emotional control. Service members are trained to accomplish the mission, put the team first, and push through discomfort. These strengths can later contribute to reluctance to seek help or to disclose distress, especially if veterans worry that they will be seen as weak or as failing to handle their responsibilities. When a clinician says, "Why did you wait so long to come in?" the veteran may hear criticism instead of concern. Another important factor is the shared language and humor that veterans often use with each other. Jokes, dark humor, and blunt language can be ways of coping with trauma and building camaraderie. To a civilian provider, this can seem off-putting or inappropriate, but within veteran culture, it may be a sign of trust. Cultural competence here means learning to hear the story beneath the language, avoiding quick judgments, and being willing to ask open, respectful questions about what certain phrases or experiences mean to the veteran sitting in front of you. The whole health model within the VA frames health as a dynamic balance of mind, body, spirit, and community, all organized around what matters most to the veteran. Instead of starting with the problem list, providers are encouraged to begin with a conversation about the veteran's values, goals, and sources of meaning using tools such as the Circle of Health and personal health planning. Research on the whole health transformation shows that when veterans participate in the whole health services, they report better engagement in care, greater sense of meaning and purpose, and modest improvements in pain and stress outcomes compared to conventional care alone. More recently, qualitative work has shown that veterans describe whole health as helping them connect physical, emotional, and social wellness in a way that feels more personalized and empowering. From a cultural competence standpoint, whole health creates space to recognize the veteran's military identity and life story without reducing them to that identity. The conversation about what matters to you makes it easier to talk about roles as parents, workers, students, community members, and spiritual beings, not just as patients carrying diagnoses. This broader framing can be especially healing for veterans who feel that their service has come to define them in ways that are limiting or painful. Turning now to mind. It is well documented that many veterans live with post-traumatic stress disorder, depression, anxiety, and moral or spiritual distress related to their service. Mental health stigma remains a central barrier. Studies of military and veteran populations show that both self-stigma and perceived public stigma reduce the likelihood of seeking care, and that leadership behaviors within the military can either reinforce or challenge those beliefs. In a recent large study of U.S. military personnel with post traumatic stress or depression symptoms, factors such as greater symptom severity, prior deployment, and concerns about career impact were all associated with differences in mental health utilization. Those who must those who most needed care were not always the ones accessing it, which is a powerful reminder that clinical need alone does not determine service use. For public health and clinical practice, this means that when we speak with veterans about mental health, we have to address culture and context, using plain, non stigmatizing language, normalizing help seeking as a sign of strength, and explicitly acknowledging the courage it takes to show up can reduce some of the perceived threat. It can also be helpful to ask about past experiences with military or VA mental health services, both positive and negative, and to validate mistrust when it is based on real experiences, while still keeping the door open to new forms of support. On the physical side, many veterans live with chronic pain, musculoskeletal injuries, traumatic brain injury, and service connected conditions that affect mobility, sleep, and daily functioning. These physical issues often interact with mental health concerns in a reinforcing cycle. Pain can worsen depression and anxiety, while untreated mental health symptoms can make pain feel more overwhelming and harder to manage. Whole health approaches have been used extensively with veterans who experience chronic pain. Program evaluations show that veterans who engage in whole health services, including health coaching and complementary and integrative health approaches, often report better experiences of care, reductions in opioid use, and small but meaningful gains in functioning and well being. Veterans describe feeling more like active participants and less like passive recipients when they are invited to co create their plans. From a cultural competence lens, it matters how we talk about pain and disability. Some veterans downplay symptoms because they compare themselves to others who they see as worse off. Others may fear being perceived as malingering. Clinicians can respond by affirming that invisible injuries are still real, by using functional language such as, "What activities are hardest for you right now?" and by explicitly linking physical care to the veteran's personal goals, such as playing with grandchildren, working, or participating in community activities. The spiritual dimension of health is especially important in veteran care. Spiritual does not necessarily mean religious, although for some veterans, faith communities are central to coping. Instead, spirit here refers to meaning, purpose, values, and the sense of being at peace with oneself and others. Many veterans wrestle with moral injury, which has been described as a distinct form of suffering that arises when individuals feel they have violated their own moral code or been betrayed by leaders or systems they trusted. Recent research has begun to quantify how widespread moral injury is among veterans. A nationally representative study estimated that about 6% of U.S. veterans meet criteria for moral injury as a clinical syndrome, and that many more experience significant moral distress related to potentially morally injurious events, such as witnessing inhumanity or feeling they failed to protect others. These experiences are strongly associated with functional impairment in daily life. Moral injury also appears to be linked to suicide risk. In a 2025 study involving veterans and other high-stress service occupations, moral injury was independently associated with suicidal thoughts and suicide attempts, even after adjusting for post-traumatic stress disorder and depression. This means that if we look only on conventional mental health symptoms and do not ask about guilt, shame, betrayal, and loss of meaning, we may miss a crucial part of the picture. Spiritually integrated care, collaboration with chaplains, and space for veterans to tell their stories without judgment are all vital components of whole health practice. Veterans' health is shaped not only by what happened during their service, but also what happens in the communities and systems they return to. Housing stability, employment opportunities, access to quality health care, transportation, and social support all play major roles in who thrives after service and who struggles. The National Academies emphasize that achieving whole health for veterans requires attention to social and structural determinants of health, not just improvements inside the clinic walls. For example, a veteran navigating chronic pain, post-traumatic stress, and unstable housing is unlikely to benefit fully from a beautifully designed whole health plan if they cannot reliably store medications, attend appointments, or sleep safely at night. Similarly, rural veterans may face long travel distances to VA facilities, limited access to specialty mental health care, and fewer peer support options. These realities shape what is possible and must be addressed through policy, community partnerships, and creative use of telehealth and mobile outreach. Cultural competence in this context means understanding that veterans are not a monolithic group. Women veterans, veterans of color, LGBTQ veterans, and student veterans, for example, may face layered inequities related to gender, race, sexuality, or educational stress status on top of their veteran identity. A one-size-fits-all approach will miss important needs that may unintentionally reproduce disparities. Whole health invites us to ask about these intersecting identities and to advocate for services that are flexible and inclusive. When we look closely at veteran populations, we see clear disparities in access, experience, and outcomes. Women veterans report higher rates of military sexual trauma and may feel less safe or welcome in male-dominated environments if services are not designed with their needs in mind. Veterans of color often face both the effects of racism in civilian life and inequities embedded in military and VA systems. LGBTQ veterans may have experienced discrimination or concealment of identity during service and may carry ongoing mistrust. Whole health has potential to reduce some of these disparities, but only if it is implemented through an equity lens. The national academies argue that the whole health frameworks should explicitly name equity as a core goal and should track outcomes among subgroups to ensure that the benefit of transformation are shared rather than concentrated among those who already have greater resources. In practice, this can mean offering female-only groups, ensuring that whole health materials use inclusive language and imagery, partnering with community-based organizations that serve veterans of color, and training staff to recognize how structural racism and discrimination shape health. It also means listening carefully to veterans who say that their past experiences with systems have been harmful and inviting them into co designing conversations about how to do better. Communication is at the heart of culturally competent care. For veterans, several common communication patterns can become barriers if providers misinterpret them. Some veterans speak very directly and may use blunt language to describe traumatic events. Others minimize their symptoms, saying things like, it's no big deal, even when they are in significant distress. Silence can mean Silence can also be meaningful, especially when topics touch on shame, moral conflict, or traumatic loss. Studies of military and veteran populations show that attitudes towards help seeking are shaped by both internal beliefs and leadership messages. When leaders normalize mental health care and model help seeking, stigma is lower and service use is higher. When leaders communicate that real soldiers handle their own problems, self-stigma increases and veterans are more likely to delay or avoid care even when they are suffering. Clinicians can bridge these communication gaps by slowing down, using open-ended questions, and explicitly naming the cultural context. Simple phrases such as, a lot of veterans were taught to push things down and drive on, sometimes that makes it hard to talk about what is going on now, can validate the veteran's experience and signal cultural awareness. Checking in about preferred forms of address, comfort with eye contact, and whether the veteran would like a family member or fellow veteran involved in visits can also support rapport. I want to return briefly to moral injury because it is both a clinical issue and a public health concern. Moral injury sits at the intersection of mental health, spiritual health, and social context. Veterans may feel abandoned by institutions, misunderstood by the public, or judged for decisions made under extreme conditions. These experiences can contribute to isolation, substance use, conflict in relationships, and suicidal ideation. The data we saw earlier suggests that hundreds of thousands of U.S. veterans may be living with functionally impairing moral injury or moral distress. Additionally, moral injury appears to add unique risk for suicidal thoughts and behaviors, even when post-traumatic stress and depression are accounted for. From a population health perspective, ignoring moral injury would mean leaving a key driver of suffering untouched. Public health responses can include training clinicians across settings to recognize moral injury, expanding access to spiritually integrated and values-focused therapies, and creating spaces outside traditional clinics where veterans can share stories, grieve, and make meaningful community. Whole Health, with its emphasis on mission, aspiration, and purpose, is well positioned to integrate moral injury work into routine care. Whole Health also encourages the use of evidence-based complementary and integrative approaches alongside conventional treatments. In the VA system, this has included yoga, Tai Chi, mindfulness training, acupuncture, and whole health coaching, among other services. Evaluations of whole health demonstrations have found that veterans who use these services often report improved engagement in care, greater sense of control, and small improvements in pain and stress outcomes. Qualitative studies show that veterans appreciate having options beyond medication alone and value practices that they can carry into their daily lives, such as breathing exercises or movement routines that help with sleep and anxiety. These practices can also resonate with the discipline and training ethos many veterans already possess. When a provider frames mindfulness as another skill to practice rather than as a vague wellness activity, veterans may be more willing to try it. Cultural competence here means introducing integrative practices in a way that feels respectful and relevant. Some veterans have spiritual or cultural beliefs that align naturally with certain practices, while others may be wary or unfamiliar. Asking permission, explaining the evidence in everyday language, and connecting recommendations to the veteran's stated goals can help ensure that these tools empower rather than alienate. For clinicians and public health professionals who want to deepen their skills, there are growing resources available. The VA offers whole health education for staff at multiple levels, including clinical courses that teach how to have, quote, what matters to you conversations, and how to incorporate whole health planning into routine visits. System level evaluations suggest that staff who participate in whole health training report shifts in how they understand their role and in their own sense of meaning at work. Outside the VA, national organizations have also begun to emphasize military cultural competence. These trainings reinforce the idea that understanding rank structure, deployment cycles, and common experiences of reintegration is not just nice to have, but ethically important for anyone serving veteran communities. From a public health practice standpoint, it is helpful to think in terms of layers. Individual clinicians can pursue training and practice new communication skills. Clinics and health systems can integrate whole health principles into workflows and policy. Communities can partner with veteran service organizations to build peer support networks and culturally grounded wellness programs. All of these levels matter. When we translate these ideas into daily practice, several core cultural competence skills stand out. The first is cultural humility, approaching each veteran as the expert on their own experience, acknowledging what we do not know, and being willing to learn. Paul reminds us that even though there are common themes in military culture, every service member and veteran has their own story shaped by branch, era, role, identity, and personal history. The second is reflective listening. This means not only hearing the content of what veterans say, but paying attention to emotions, values, and meaning. When a veteran says, I should have done more, a culturally competent provider might respond, it sounds like you carry a lot of responsibility for what happened, and then gently explore the context instead of jumping straight to reassurance. This kind of listening is crucial for addressing moral injury and building trust. The third is shared decision making. Whole health encourages collaborative goal setting and recognizes that veterans bring strengths, preferences, and social contexts and must inform care plans, asking, given everything we've talked about today, what feels most important for us to tackle first, honors the veteran's agency and can improve follow through. Cultural competence is not a checklist. It is an ongoing practice of curiosity, respect, and partnership. From a public health perspective, veterans' whole health is not solely the responsibility of the VA or any single clinician. It is a shared responsibility across systems, including community health centers, academic medical centers, local health departments, and policymakers. The national academies call for a whole health approach that extends beyond veterans to the broader U.S. population, but they also highlight veterans as a priority group for early implementation and learning. Surveillance and research plays a role here. Studies quantifying the prevalence of moral injury, mental health conditions, and barriers to care among veterans provide essential data for planning programs and allocating resources. Evaluation of whole health initiatives help us to understand what is working, for whom, and under what conditions. Advocacy is another key responsibility. Public health professionals can use their voice to support policies that expand access to whole health services, invest in peer support and complementary therapies, and address underlying social determinants such as housing, employment, and education. They can also push for inclusion of veteran perspectives in planning processes, ensuring that cultural competence is informed by lived experience rather than assumptions. As I begin to close, I want to invite a moment of reflection. Working with veterans can be both deeply rewarding and emotionally complex. Many of us bring our own family histories, beliefs about war and service, and emotional reactions to hearing trauma stories. Cultural competence includes recognizing our own reactions, seeking supervision or support when needed, and committing to ongoing learning. At the same time, veteran communities carry tremendous resilience, creativity, and strength. Whole health frameworks remind us to notice and build on those strengths rather than viewing veterans only through the lens of problems or deficits. When we slow down enough to ask what matters to you, we often hear about family, community, service, creativity, and healing. Those answers can guide both clinical care and public health planning. If you work in a healthcare setting, I encourage you to think about one concrete change you could make to better support veterans' whole health. That might be learning about military culture, incorporating whole health questions into your assessments, or partnering with a veteran led organization in your community. In conclusion, veterans' whole health requires attention to mind, body, and spirit within the context of a distinct and diverse culture. Military and veteran culture shapes how people communicate, how they think about seeking help, and how they make sense of illness and recovery. Whole health provides a framework for honoring those experiences while empowering veterans to define what health and well being means for them. We have seen that moral injury, stigma, and social determinants of health are not abstract concepts, but lived realities with measurable impacts on functioning and suicide risk. At the same time, we have strong evidence that person centered, integrative approaches such as whole health can improve engagement, meaning, and aspects of well being for many veterans. Thank you for your attention and for your commitment to caring for veterans in ways that are culturally competent, compassionate, and grounded in whole health personal care. My hope is that this presentation offers both practical tools and a renewed sense of respect for the complexity and strength of veteran communities. And these are my references. And that is all. Thank you.